So the purpose of this today was to try and for you to appreciate, for those of you who are clinicians, and I see a couple of you in the audience are going to say, oh my gosh, why am I here, i.e. Alana, and you don't necessarily have to sit here through this, but if you want to hear at least what the rest of the non-sort of genetically trained people are listening to, you're more than welcome to listen. So again, I recognize many of you by this point, but how many of you are clinicians again, in terms of someone who might have seen this before? Okay, and how many of you are in training at some level? All of us are always learning, but specifically in training, okay. And how many of you are more on the research side of things in terms of hardcore sort of researchers and in the basic science, and how many of you are informaticians? Versus how many of you might be sort of more social scientists or interested in the other implications of what this might be. Okay, so we're going to try and, as usual, include a little bit for everyone. And this is going to be what it's like down in the trenches. And so some of my colleagues may want to chime in as we go along with things, but we're going to try and think about now in the clinical arena, how are people using genetic and genomic testing? What are some of the issues that come up in terms of the limitations? We're going to try and bring in some of the issues that come in terms of cost and utility. And I have to say, just having come back from the American College of Medical Genetics meeting last week, somewhat depressing and sobering to me in terms of, at least from a practical point of view, difficulty that we're having being able to get coverage for the testing. So although everyone, I think, on the clinical side and the scientific side appreciates how important it is, it's difficult to convince insurance companies right now to be able to pay for this. So anyway, one of the points that I wanted to make is the American College of Medical Genetics actually just came out with a recent sort of policy statement that a diagnosis, in fact, does matter. So beyond, what has specific clinical treatments and clinical recommendations in terms of medical actions that you might take, the college came out with a bold statement that just simply having a diagnosis matters. That is, being able to have a label on what you or your family's condition is important for a lot of reasons that have to do with just the family and being able to have them get closure on things, having them understand prognosis. And so this is something I've told you guys before in my introductory lecture, but one thing that's changed since that, whatever we are now, 3 months since I gave that lecture, is, like I said, now a diagnosis officially, at least in terms of the college's mind, matters just to have a diagnosis, even if there's none of the other wonderful things we've been talking about. Whether or not insurance companies agree with that is what we're waiting to see, but at least that is one statement that's out there. So you've seen this slide before, just saying that now, as the cost of sequencing has decreased tremendously, there are new opportunities in terms of sequencing. What's interesting is the way the community has sort of responded to this is to improve clinical utility, to sequence more and try and sequence it faster, but not necessarily drive down the cost of a genetic test per se. I think it's really been more sort of the idea of a genetic test might cost something like $2,000, but how can you get more for your money? And the interesting thing about this is insurance companies rather are pushing back and saying, we want you to drive down the cost of the sequencing to, sort of the hundreds of dollars of range, and try and see, if you can come up with getting clinical utility from that end. I'm going to put out here just, again, this is to a certain extent a free-for-all, free association from my end. But one of the things that's interesting, just so you understand what's out there in terms of dynamics, for those of you that are interested in the business side of things or other side of things, there are many, if you watch in terms of new companies that get into this space, so many of you have heard about a company called Foundation Medicine, for instance, that does testing. This is now tumor sequencing, and many other early startup companies. What's interesting to watch from a business point of view is many of them get started by VC money. They get a huge infusion of cash to be able to do something, and as they start out doing this, Foundation's sort of theory was sequence everything. Like, money is no object. We've got a lot of VC funds, so we'll do sequence everything. And then when it came down to actually scaling this, this test, when they originally came out, was basically about a $5,000 test. And when you think about, you're getting a huge amount of information, what you actually do with it clinically ends up being relatively little. And so the interesting dynamic has been, and I have to say, from a business point of view, Foundation really didn't have to demonstrate that they were actually making money on this. What they had to do from a business point of view to get investors was to be able to do more tests and to get, someone to believe that there was something there. And then, of course, after they went public in terms of doing this, they were able to basically cash out. And from a point of view in terms of whether or not they provide clinical utility, to be totally honest, that wasn't their business plan. They didn't really care about that. What their business plan was to be able to sell themselves and to make quite a bit of profit in doing so. So the interesting thing is if you start looking out in the space in here, there are companies like Invitae and other companies that are basically doing the same thing when it doesn't have to do just with tumor sequencing, but now when it comes to germline testing. And so if you look at the business models around several of these, it's very interesting because for them to, again, I bet, sort of mark my words, you'll watch this go forward. Invitae, again, right now has a lot of VC money, about $150 million in terms of doing this. And in terms of the testing they offer, what they need to do is demonstrate that there are actually a number of people that are investing in terms of doing that. And from an interesting point of view, what they're doing is basically cutting costs tremendously down to the point where basically diagnostic laboratories can't compete. But what will be interesting is, again, we'll see whether or not the prediction is true, if they end up driving people out of the market who are actually providing a good clinical service by just undercutting them, at the end of the day, once they've sort of gone public and made from a business side the money they needed to do, what's left for the healthcare community in terms of being able to do that. And so it's just interesting for me to sit there and watch what's going on. And it's at this point what I would say is if you watch the market, it's a race to the bottom. Sort of how low can you go before you drive out all your competition? Once you drive out all your competition, either you're the only one left and you're standing and you now have a monopoly, which is a wonderful situation if you're that company, or you just destroyed the whole industry. And whether or not that ends up being what it is, we'll end up seeing. But insurance companies are just sitting back basically trying to limit their cost in terms of any of the testing that we're talking about. And as you've already heard me say, one of the limitations in terms of how low you can drive this price is really with the reagent costs that come from Illumina, and Illumina at this point is clearly a monopoly in that business. So what are the things that matter to us as clinicians in terms of being able to do these? And as you've heard me talk about before, there are sort of macro-level tests and micro-level tests. And you've heard me sort of harangue a little bit in terms of cost, but cost is a big issue because cost is ultimately what insurance companies have to pay for or our patients have to pay for in terms of out-of-pocket costs. Turnaround time is something very important to us from a clinical point of view. As you can imagine, for instance, some of our results, I'm just looking at Kathy up there in the top row, some of our cases, for instance, of breast cancer or other types of cancers. After a new diagnosis, we're trying to understand what the underlying cause for that was, in part because we're trying to make oftentimes surgical decisions and get that information quite quickly. So just as an example, when we first started out, this is now specifically within the sphere of breast cancer testing, when we started doing this, gosh, like 12 years ago, turnaround time was 8 weeks. And people weren't actually in the same mindset of using that information to make those surgical decisions right at that time. People were thinking, well, I need to make this, know this information because long-term I'm worried about a second independent primary and I'm working about long-term screening. But we've pushed, and in a good way, it was literally sort of pushed because the community pushed Myriad to turn around to decrease their turnaround time down to 3 weeks and now down to even 2 weeks. And once you did that, once you decreased the turnaround time, there suddenly became a new clinical opportunity for how you use that information so that you could decide, for instance, if you knew you had DCIS, ductal carcinoma in situ, or primary breast cancer, if you knew it was because of an Angelina Jolie type of case of BRCA1 or 2, maybe you were going to decide instead of a lumpectomy that you were going to have a unilateral or bilateral mastectomy. But because of that, people have been using that information. One of the things for those of you who are just, not actively doing this, but just kind of voyeuristically sitting on the sidelines watching this, is watch what happens to the turnaround time for some of these things. So some of the tests that we're going to talk about, including things like whole exome sequencing, sort of the standard within out there, what we can access right now is anywhere from 4 to 6 months in terms of turnaround time. And so being able to get a diagnosis and get an answer, you can imagine if you're waiting 6 months for a diagnosis for an answer, that has very, very different clinical utility than if you're waiting 6 days for an answer, right? So one of the things, again, that's come out in the market that's interesting to be able to see is there's now a couple laboratories that are actually pushing that envelope. So can you actually get something like whole genome sequencing, whole exome sequencing, where your turnaround time really now is something like 7 days? So in other words, if it's a change in terms of, for instance, a newborn baby who's in the neonatal intensive care unit, some kid or some adult who's crashing and burning in one of the intensive care units, units where you're really trying to do this in terms of a life-saving procedure, or just you're trying to get at a diagnosis quickly. The prenatal market is ultimately, I think, going to be the next one of these if we can get the turnaround time correctly for these. But again, that issue of turnaround time makes a big difference in terms of how these tests are clinically utilized. The other part of this, which we'll get into, and we've talked a little bit about before, but is the question of whether or not you get a clear-cut answer. Do you get a clear-cut answer, yes or no, or do you end up in this sort of level of uncertainty with variants of uncertain significance? And certainly, the more you end up in this gray area variants of uncertain significance, the less clinical utility it has. Just to give you some ideas, people have been thinking about this in all sorts of dimensions, and the question for the community that some of you know is that there are, sort of a 5-point scale or a 5-part scale in terms of variants that are clearly disease-causing at the one end of the spectrum to at the other end of the spectrum, variants that are clearly just benign polymorphisms, normal variants, and then there are these 3 other categories in the middle. There have been some people that have, sort of said, well, why don't we just do this? We'll report out things that are at the highest level of certainty in terms of being bad, so pathogenic or variant likely pathogenic, and just forget all the rest. You don't really know what to do with that anyway. Just don't report it, don't bother it, don't worry about it. Just forget about it, but let's only give you sort of quote-unquote news you can use in terms of that. And I'm just looking at people's reactions in the audience because some of you that know what you're doing are looking at me like I'm nuts. But that is at least something that's been suggested in the community about potentially doing that, but minimizing the burden on people in terms of uncertainty. So the reason I bring all of these up is because that's sort of on the right are the factors that at least I consider clinically in terms of being able to do this. And the last of these is that it depends on whether or not you're really doing this for a gene that's already known or whether or not you're really using this to be able to identify new genes that we might not know about. And you may have to be more expansive or more general in terms of your testing platform that you use if you don't know exactly what you're going after. So in doing these, again, in terms of thinking about, this is now the left side of the scale here, the thing that's giving you the highest level view you'll remember is a karyotype, although the resolution's not so great, so we use things like chromosome microarray, and then again use sequencing methodologies like Peter talked about a couple weeks ago in terms of exome or genome sequencing, and the thing that we're increasingly trying to do is use those sequencing-based platforms of exome and increasingly genome sequencing to get the same type of information that we were getting from, for instance, karyotypes or chromosome microarray, that is looking at copy number of variations, structural translocations, but being able to have essentially a single platform from which you can get all the information and not have to do these competing platforms. So I'm just going to, out of curiosity, I at least know what the list prices of these things are. I don't necessarily know all the time what insurance companies pay for these, but we're going to do sort of a vote in this in terms of thinking about what these things should cost. So at this point, for instance, if you had a test, so as an example, some of us go through and we get carrier screening for things like cystic fibrosis, which is a common thing that people that are thinking about having kids get screened for. It's one of the recommendations. I'm going to, give you some options in terms of how much you think that test might cost if I were to, as a laboratory, offer that to you. I'm going to throw out some numbers. I'll give you 3 choices. We'll make this relatively simple. $50, $250, $750. What do you think that should be in terms of the cost of that test? What should an insurance company pay for that? So you're just going to vote. $50. It's a $50 test. That's what it should be. $250. It should be about that. And $750. Okay, so for those of you who voted $250, that's a sweet spot. Right now, that's about what an insurance company is going to charge for you to get cystic fibrosis testing. This is interrogating usually 23 different spots, relatively straightforward in terms of doing that. So you're getting a little bit of information, I would argue, for that, but potentially that. Okay, so let's think about another one of these. So maybe you're going to not just look at one gene for specific mutations, but maybe you're going to do, you think the differential diagnosis is something like a rare disorder. You need to sequence through that entire gene. And we'll say it's an average size gene, which to us usually means about 10 exons, for those of you who know this. Again, I'm going to give you a choice of prices. Should this be a $100 test, a $500 test, a $1,000 test? Within those, knowing that this is one single gene, only one of 20,000 genes you're looking at, but one single gene. But as you're looking at it to completion and to perfection, you're going to get a really good interpretation of whatever this particular gene is. And as an example, this now might be the cystic fibrosis gene, CFTR, but now you're looking at it, sort of in the entirety, not looking at 23 hotspots, but looking at all of it. So again, $100 test, $500 test, $1,000 test. Okay, about $1,000, just for people who know that's about what the price is out there for this. Okay, so now say that in particular you might be thinking about a particular condition, a particular clinical condition, but this is something where there's not just one gene associated with it. So I'll give you one of the common indications. We have multiple, for instance, breast cancer genes, right? So, actually, I'll throw one of these in here because this is an interesting sociological question. So, for instance, if one of these genes was now, say, for instance, we'll combine these two, BRCA1 and BRCA2. Again, what should the price of that be? The choices here are $100, $500, $1,000. Again, BRCA1 and 2, you know a little bit about the clinical utility, but complete sequencing of those genes. What would you guess? $100 for that test? You might say, very common test. Everyone orders that. $500 for that test. $1,000 for that test. Myriad, when they first started offering this test, a $3,500 test. Okay, so just realize that in terms of the early days of doing this. Okay, now I'll say BRCA1 and 2, that's fine, but in fact, I could offer you, say, 25 different genes for hereditary breast cancer. So not just one of these, but 25. We're now going to use this next generation sequencing to do this. And again, in terms of what an insurance company might pay for this, should this be, these are their choices, a $500 test, a $1,000 test, a $2,000 test. And again, this is today now. This is not, sort of 2 years ago when Myriad was charging their $3,500, but today, what would you guess the price of that should be? So a $500 test, a $1,000 test, a $2,000 test. Okay, so $2,000 is about what this goes for on the market right now. Actually, what insurance companies pay for this is probably closer to the $500 part of this, but at least, companies will charge about $200 to be able to do this. Okay, a karyotype. So remember, this is something you're going to look at the chromosomes under the microscope. You've got a technologist that's going to strain their eyes to be able to do this. But all you're getting is sort of high-level information, right? So is this, again, is this a $100 test, a $500 test, a $1,000 test, do you think, to be able to do that? $100, just looking at chromosomes. $500, $1,000. It's about a $1,000 test, interestingly enough. So, some of you are like, oh my gosh, are you kidding me? But because it's very labor intensive in terms of having to do things like grow the cells, drop the chromosomes, someone who's got a very trained eye to be able to do this, it just shows you again, when something's not automatable, scalable, you can imagine it ends up being quite expensive. Okay, now here come the big enchiladas. Exome sequencing. This is a 20,000 gene panel, right, essentially. So 20,000 genes. What would you guess the cost for doing something like that would be? Is this a $500 test, a $2,000 test, a $10,000 test? What do you think? 500, what did I say, $500? Is that what I started with? I feel like an auctioneer here. Who's going to pay $500 for this? Give me once, give me twice. Who would pay $500 for this? 2,000? 10,000? Okay, so it actually goes for, in terms of a list price, about a $10,000 test at this point. Again, in terms of how much insurance companies pay for this, it's probably about, a quarter of that at best in terms of doing this. But I just want to give you sort of a sense of the scale of different things and how much these things are costing based on how much is actually involved in being able to do these different types of tests. So one of the things that's incredibly confusing for practitioners, and I have to say after doing several different surveys of various different types of practitioners, neurologists, psychiatrists, cardiologists, generalists, it's amazing to me what they know and what they don't know about this. And so here's the problem. All the time clinicians get bombarded with, we've got a new genetic test for whatever it is. I've got a new genetic, some company comes and says, I've got a new genetic test for Alzheimer's disease. I've got a new genetic test for Parkinson's disease. I've got one for depression. I've got one for, whatever ails you. And the problem is that for many clinicians, being able to think critically through scientifically, is this a good test or not? Is this one that's going to be sort of valuable and have clinical utility, is sometimes quite confusing. And so the first time this came in was with 23andMe in terms of, really sort of hitting the press and from a policy point of view. So the limitation with 23andMe in terms of this is when people were originally thinking about well, let me ask an interesting question. So one question that I didn't realize until relatively recently, i.e. a couple of years ago, was what the business model was for 23andMe. So you might have thought the business model, by the way, 23andMe testing you can now get for $99 in terms of doing the testing. Originally this was like a $1,000 test, we just talked about prices. This became a $99 test. And so originally when this was a $1,000 test, I assumed, okay, well your business model is that you're making money doing testing. testing. You're having to do testing, you're getting paid for that, and you're making a profit in doing the testing. In reality, though, that's not the business model for 23andMe. The interesting business model for 23andMe, for any of you who have done the test or planning on doing the test, read the fine print of when you say accept in that consent form that you actually sign. Read that fine print about what you're actually agreeing to as you're doing it. You may decide it's a really great idea, and I applaud you if you do, but you also may not have realized what you were getting yourself into. Essentially, what you've gotten yourself into is donating all of your genetic data to 23andMe so that they can basically sell it to other people and be able to make money off of your genetic information. So based on what you've reported, based on them now having a sample of your DNA and being able to learn all sorts of things from it, that's the business model in terms of how they actually make money. It's not off of your $99 that you're paying for the genotyping and the reporting you're giving back. That's how they actually do it. But the question and the reason why the FDA got sort of involved in terms of 23andMe was that they were advertising to do something that they really were not doing in terms of this. So again, the idea being, you know, could you find out if you were going to have Alzheimer's? Could you find out if you were going to have breast cancer? Could you find out if you were going to have diabetes? A lot of people who came into this who were, and again, this was largely direct-to-consumer marketing, so this idea that you could go directly to the public, there were a lot of people who were, you know, quite sophisticated consumers that had good reasons for wanting to be able to take care of themselves going forward, and they bought into this idea that you could, through this type of genetic test, get some sort of risk assessment, accurate risk assessment for your risk for all of these very common diseases. For those of you that understand the technology behind this, 23andMe basically did a bunch of genotyping for a bunch of very common variations that are common within the population that do explain some portion of the risk variance associated with things like diabetes or obesity or asthma or breast cancer or things like that. But in fact, the percentage of the variance they accounted for was on the order for most diseases of about 5%. And so the problem is that although you might have understood 5% of the genetic contribution to one of these conditions, there's still 95% of all of that variance that you were missing, and so how accurate that is predicting is really terrible. And so in terms of being able to do that, you might have either thought that you were at very high risk based on a small amount of the information, or even worse, potentially thought that you were at very low risk when in fact you could have been at higher risk for one of these conditions, and you might have been falsely sort of reassured that you were not at risk. On the other hand, one of the things that's interesting, and I have to say I've had patients come to me in this way, is that there are things that are genetic like that. They've got a small percentage of the risk that's accounted for, and there are things that are genetic! And those things that are genetic that they tested for with 23andMe included, for instance, the 3 Ashkenazi mutations in BRCA1 and BRCA2. And it wasn't, some people who are really sophisticated consumers about this actually got around the myriad patents by getting 23andMe testing because they were Jewish, and this particular test for them actually ended up having very high clinical utility, and you could get that result for $99 basically, rather than having to go through myriad and pay much more for the test. So people who understood the system worked the system, and that was great. And I have to tell you, I've had, just Monday, I can say I had a patient come to me because of their 23andMe test results that showed that they had a particular BRCA mutation, and in a good way, you know, we're using it in a helpful way. Now, that particular risk variant actually now increases your risk for tenfold, for instance, for a risk of hereditary breast cancer. So that's not a relative risk of these other things like 1.1 or 1.2 or, you know, a small percent of the risk variance. That really is something that has clinical utility, and in fact, as I think I've mentioned before, is the one genetic test that's covered under the Affordable Care Act. For people who meet the criteria, that is the one genetic test that under Obamacare is covered. So the thing that gets very confusing for the consumers who are coming in and doing 23andMe is am I talking about one of these sort of very strong, powerful hereditary risks, like a BRCA2, 185 del-AG mutation, or am I talking about one of these wimpy sort of things that might be a small percent of the genetic variance that's accounting for a relative risk of something like 1.1? The average consumer, and I dare say the average physician, that was trained probably more than 5 years ago, they don't necessarily distinguish between those two. And this is not a criticism. I'm just saying that it's very, from their point of view, it's hard to distinguish and understand the difference. And so there's been a lot of concern in the community about how do you deal with this. And so from the government's point of view, their solution to this was, we're the FDA, we're just going to regulate this. And if we regulate this and we're the ones that oversee this, we can make sure that we somehow educate the public about these differences and make sure that laboratories that are trying to sell this really are selling, you know, they're not falsely advertising, they're really delivering on what they can say. And I don't have time to go into all of the things with the FDA, but there's certainly, as many of you know, there's a very active discussion right now about FDA and regulation in this space. But the point in this, and some of us in the genomics community, and I'd appreciate other people's thoughts, have thought, well, maybe this should be something where we've got good regulations in place. We've certainly got CLIA, we've got CAP in terms of being able to supervise laboratories for this. And maybe there ought to be something where, for instance, you've got an independent panel of geneticists and genomicists that really understand this space who could give something like stars, so like you do this on movie ratings, 4 stars or a seal of approval or something like that might be being able to say that a certain test has clinical utility, and something that really is, not, if you actually, read some of these things, there are all sorts of things people will try and sell you a genetic test for, some of these things that really don't have the same sort of clinical utility. So anyway, that's part of the concern out there, is what really does have clinical utility as you're doing this. So for those of you who are actually in the trenches, this is probably the most useful slide of today. So write down this URL address, or remember the registration for this. The Genetic Test Registry is the government's way of being able to try and organize access in terms of hopefully getting to this type of information and being able to make it relatively transparent in terms of what the test is, who offers it, things like that. I'm not going to go through this live because I'll just end up having a bad web connection, and we'll sit here for 5 minutes waiting for the connection. But for those of you who want to do this, one of the things you'll be able to see is, for instance, there's this little circle with a C if there's a clinical test for it. There's a little circle with an R if there's a research test for it. It can get quite confusing, unfortunately, now, because you can search either by gene, you can search by disease name, or in some cases you can search by a panel if it's for a panel of genes associated with a particular phenotype. So for instance, a cardiomyopathy panel or a breast cancer panel or something like that. So your homework assignment is actually, for any of you that are interested, go onto the website, look and see what's available. They will try and give you, hopefully with transparency, information about the methodology that's used for the test. So for instance, is it a sequencing-based test? Does it cover copy number variations? So what we'll call deletion duplication analysis. It'll tell you where the laboratory is. So one of the interesting things you'll see is that for some indications, you'll see that there may be only one lab in the world if it's a really rare condition that you're interested. In other cases, you're going to see almost 52 different laboratories, all that may offer something. It's, again, trying to be there so you can, as a physician, compare across laboratories relatively quickly, relatively easily, or even just to see if there is a laboratory that offers the test for your particular condition. And I have to say, I still get emails or pages or calls, I swear to you, at least twice a day about, is there a genetic test for my particular disorder? And I so wish that people would just go to the website, because it would make my life easier. But to be able to see that there are tests that are available now really for any gene, so that now that we can do things like whole exome, whole genome sequencing, your gene is undoubtedly covered, at least to a certain extent, by those sort of universal ways of doing this. And even for the rarest of the rare disorders, there at least now is a test. Before, there usually were only tests for about 1,500 genes, but really there's no excuse not to be able to get the testing, at least from a technological point of view, if you wanted to. Eventually, we'll see, in terms of this, one of the Genetic Test Registry's original ways of doing this was also that you could comparison shop between this. It hasn't quite come to that in terms of price shopping, but the idea, so it's not quite, like Amazon yet, but the idea now is that you at least can compare based on the technologies and based on, again, the technical parameters, what you might want to do. Okay, so I'm going to try and run quickly through the different types of indications or the ways that we do testing from clinical points of view and try and give you a sense of where things are and where things are going. So as I said, carrier screening is something we've been doing for a long, long time, really for the idea of reproductive planning. So for couples who are thinking about having children and to think about doing this in a way that was hopefully helpful to the community. It's been interesting to see how this evolved. There were certain conditions, and I'm thinking around the world globally, certain conditions that were sort of early adopters, the hemoglobinopathies, so things like sickle cell disease and thalassemia that obviously have a high prevalence in certain parts of the world, were one of the earliest of adopters. Cystic fibrosis came next in terms of a lot of this. And then I think we as a genetics community took a step back, and I should also say Tay-Sachs was an important one within the Jewish population. Then many of us took a step back and said, well, if you're starting to do this carrier screening, you're only accounting for a little tiny bit of the mutation burden within the population. If you really care about about offering parents the option of having healthy children, shouldn't you do something that's more common in terms of that? So within all of this, one of the things one has to think about, though, is if you start down this road, make sure you've got everything else to support this. So if you are identifying within this, you're trying to identify couples who are both carriers for the same condition, what are people going to do with that information, and do you have the technology, the healthcare system to be able to support that? Because you might say, well, one decision tree is either I have or don't have children. I will tell you for most couples that not having children is not the answer they want to hear. But there are options of adoption. I have to say adoption is much, much harder these days than it used to be, so that's not as viable an option. As we'll talk about, there are options of prenatal testing or even pre-conception testing. But if you're going to start down this road, you need to have something to do with that. And so again, one of the companies that really made a breakthrough in this is a company called Counsel, and they were really thinking outside of the box in terms of this. They decided if the infrastructure is in place and you're going to get a sample and you're going to run cystic fibrosis, for instance, why stop at cystic fibrosis? Let's really think about mutation burden within populations, and within the United States, especially more so than other parts of the world, individuals either don't always know their ancestry or they may come from mixed ancestry. So it may not be, you may be half Jewish or a quarter Jewish, and so you'd want to get the Jewish panel within this, but maybe the other half of you is Chinese, and so you want to think about mutations from that part of the world. And so as they started thinking about this, they started thinking about really pan-ethnic screening, so not necessarily worried if someone was adopted, if someone didn't correctly assess where their grandparents came from, being able to think about one size fits all in terms of that. And Counsel has done this, and they now do over 100 different diseases, over 500 or maybe we're up to 600 different mutations, but again, trying to account for a large percentage of the population. I will still tell you that even though that was a great big leap forward, and interestingly enough, the cost associated with this, remember we were talking about cystic fibrosis testing being about $250, as you'll see the cost for this ends up scaling, and it's really incrementally just a small amount more. They started out by offering this as basically a $350 test. So again, if you're trying to figure out how much bang do you get for your buck, big additional bang that you get for your buck for something like this. The limitation with this still, though, is you're still, I'll be honest with you, accounting for a relatively small proportion of the disease burden or the mutation burden that's out there. And so people have even started, this is actually a research study that's being done by Katrina Goddard out at Kaiser, now thinking about do you do, in fact, whole exome sequencing to do carrier screening really for everything, just put everything under the sun and think about in a very big way anything that you could do. That ends up being very tricky in terms of interpreting all of those different variations as mutations at this point. So I think right now, today, that's probably going a little bit too far in terms of doing that. But companies are starting to do this now as a sequence-based test, not just to look for individual mutations, but try and look for an increasing amount of the disease burden, at least in terms of diseases that have sort of a big burden of disease in terms of medical care dollars and effort that's put into this, as well as just based on frequency and population-based frequency. The interesting thing is, as this is springing up, you can imagine that the right answer, this is now population genetics, the right answer, for instance, in Wisconsin, for what you do as a carrier screen there, might be very, very different than in Rihad, what you would do in terms of the mutations or anything else. And so in a very interesting way, what you're starting to see is, especially in different parts of the world where intermarriage is more common, you're starting to see spring up basically mutation panels and disease panels that are regionally specific based on those parts of the world, which to me makes very much perfect sense. And it's actually being very, very widely adopted in parts of the Middle East, especially where there's a lot of consanguinity and intermarriage, because there's a very high disease burden with these types of conditions from a public health point of view in those parts of the world. So again, I'm not making any judgments about what people do with this information, but again, sort of me being a pro-choice person, I think it's important for couples, at least if they want to have this information ahead of time. The tricky part comes with what do you do as the next step of that. So say, for instance, and one very clear thing that I want to state is that as you're doing this from my point of view, ideally this is something you offer to couples before they conceive, right? So before they're actually in the point of having a baby, in process. The best in terms of giving all their options is before they ever conceive. Not all couples think that far ahead. I understand that, but that is the ideal way of doing this. So the next question comes, if you, already are pregnant, and if you're worried about this or other conditions, what can you do with that? And many of you that already know this space know that obviously there are invasive methods of doing the testing, so things like amniocentesis, and I'm just going to give you some practical clinical points of view. This is something that for the safety of the fetus, the growing fetus, we usually don't do until about 16 weeks of gestation. For those of you who have been pregnant before, you know that at least if you're in tune with your body, you can start feeling the fetus moving about that point. You can start sort of seeing you've got a little bump there that at least those of us, at least well, anyway, just to say you've got a little bump there. Let me leave it like that. So from a psychological point of view, I'm just saying there's a different sort of connection that people sometimes have with that. And it makes it harder in terms of thinking about what you would do with that information, because it's essentially either planning ahead for the delivery of a child who might have special health needs or special needs in general, or terminating a pregnancy, which can be hard, period, if it's even within your sort of decision possibilities. But it makes it much harder, I would say, at least in my experience, once you have that connection. So because of that, people have pushed the envelope in terms of doing that procedure earlier. So chorionic villus sampling, or CVS, is something that's done earlier in the pregnancy. We really can only safely do that about 10.5 weeks of the pregnancy. The limitation with that is that you really need someone who's really quite skilled at being able to do that. Otherwise, there can be problems with complications. Ron Wapner, were he here, is one of the most skilled people in terms of doing that. So as we do this, it can be done very safely and effectively, but done in good hands is what I would say. So these are options, and these are good options, especially when you end up with one of these situations where you find both parents are carriers. But in fact, one of the reasons a lot of this genetic testing started was for conditions like Down syndrome. So this idea that there might be an increased risk, and it might be associated with an increased maternal age. So a lot of this testing started with that. I won't go through all of the history of that, but we had screening tests that were not bad and have gotten better over time, and we were applying them to the general population. So both 19-year-old mothers as well as 42-year-old mothers, even though that risk was different, we wanted something in the general population. But the real limitation of those different biomarkers that we used, and these were everything from maternal serum markers to ultrasound markers that we've used. Again, if you think about the cost associated with that type of screening, the average cost for the ultrasound plus the biomarkers you were running in the blood generally was running about $1,200. So just keep that as sort of your benchmark. And so when this ability to do this very deep sequencing at relatively low cost came this new possibility that was the holy grail people had been wanting to do, but now suddenly became realizable. So the first thing people tried doing, and I have to admit my husband's thesis advisor from 25 years ago had been trying to do this for 25 years, was to isolate circulating fetal bloods within the maternal serum. The idea that if you could actually isolate those, you could look at those fetal chromosomes under the microscope, you could see if there was Down syndrome. That still is not the most efficient way to go, but what people suddenly realized is that there was actually fragmented fetal DNA floating around in the mom's blood from very, very early in the pregnancy, and if you could sequence deeply enough, and you really have to sequence deeply enough, so it's expensive, then you can actually see if you have an overrepresentation of any one chromosome or potentially even an underrepresentation of certain parts of chromosomes. And so many of you know this, at least the New York Times version of this. This is now possible to do in terms of being able to screen for things like Down syndrome. For those of you who are really interested, look at the New England Journal of Medicine. There's a new interesting paper that just came out that actually, for those of you who are really interested, will pit sort of technologies against each other and to see how well this works. One of the punchlines from the New England Journal paper, though, is to be able to say that this screening test is just a screening test. It is not a diagnostic test. There are false positives as well as false negatives for a variety of reasons. And although it's a very, very good screening test, it is still just a screening test. And so the indications for these are still largely the aneuploidies, the common ones 13, 18, and 21. And again, if you think about the sensitivity here, the sensitivity is really, really quite good. The specificity, I would argue, is also very good, but it's just not perfect. And that's what the New England Journal paper is saying. So within this, as you're doing this, really what you're doing is sequencing, in this case for chromosome 21, and it's a counting experiment. So you actually don't have to see the sequence in terms of being able to see the A's, T's, G's, and C's, except that you use that information to map that region back to chromosome 21, but you don't have to have perfect sequencing to be able to do so. It's just a counting experiment, and it's counting to see, do you have a relatively increased number of 21 chromosomes relative to all the others, or do you have essentially the normal amount? And this is really not making a distinction distinction between the maternal and the fetal. It's just looking at all that DNA that's freely floating there, knowing that there's an enrichment process that it goes through for that fetal DNA. So the interesting thing about this is, again, I'm giving you just a little bit of history. The first laboratory that started out with this testing did it in the most sort of beautiful way, Sequenom, which actually even has some ties to Columbia here. The first version of this test, I'll give you some choices. This particular test, based on clinically how you would use it, should this be a $500 test? Should it be a $1,000 test? Should it be a $2,000 test? You know, what would you think in terms of what our healthcare system could and should be able to afford for something like this? So should this be a $500 test? Should this be a $1,000 test? Should this be a $2,000 test? So when Sequenom first came out with this was actually about a $2,500 test to be able to do this. And again, based on individual other companies coming into this and in a good way putting in competition to be able to do this better, remembering sort of that the standard in terms of ultrasounds, other types of testing is that it's about $1,200 to be competitive. The cost of this testing is now for many laboratories more in the order of $700 to $800 in terms of being able to do this test. So relatively quickly actually bringing down the cost of the testing to something that probably is more in line with what you can do, at least for Down syndrome and other types of aneuploidies. So ultimately, though, in terms of doing this, at least for the single gene disorders, so things like sickle cell disease or cystic fibrosis or spinal muscular atrophy, the question becomes that you don't want to wait until you're pregnant for these because you know your risk could be something like 25%, or even for something like Huntington's disease, could be 50%. So do you have any options of doing this before the point of conception, because termination of pregnancy is either just not an option for certain individuals or certainly not an optimal option for them. And so as many of you know, we've developed this methodology of pre-implantation genetic diagnosis. You essentially make a test tube baby, and before you transfer that test tube baby into the woman's womb, you genetically determine whether or not that embryo is going to be clean or not. Again, I'm not meaning to focus totally on the money, but I do want you to sort of get an empirical sense of whether or not this is something viable. So the actual genetic test on the embryo, so just the genetic test on the embryo, that's what we're talking in terms of the cost here. Again, usually you're testing for maybe 2 mutations, so it's just 2 mutations that you're looking at, but on the other hand, as you're doing this, you're actually doing this on just one single cell. So from a technical point of view, it takes a lot more sort of precision, the stakes are high, you have to have a lot more sort of quality control within this process. Again, for something like a 2 mutation test, should this be a $500 test, a $1,000 test, a $2,000 test? What do you think? $500? $1,000? $2,000? So this actually runs for about $2,500 to be able to do this pre-implantation genetic diagnosis, just for the laboratory to do the actual testing on it. Now, the whole enchilada. If you actually want to go through in vitro fertilization, actually paying them to do the biopsy, going through and doing this, the question is, what does it cost you, all told, to actually take a baby home from this process? So in other words, as many rounds of IVF as it takes you to go through this, to go through the pre-implantation genetic diagnosis, if you really want to have a baby using all of this, on average, all told, what does it end up costing you to have this baby? Okay, so the choices are $5,000 baby, $20,000 baby, $50,000 baby. What do you think? $5,000 baby, $20,000 baby, $50,000 baby. Actually, on average, it can cost $50,000 to $100,000 for a baby that ends up going through like this, depending on exactly how old the mom is and the couple and whether or not they've got fertility issues. But in general, this will oftentimes take more than one cycle for them to be successful and take home a baby from this process. And interestingly enough, if we think about access to care, this is the type of thing that insurance companies, understanding that there's a big cost associated with this, right? Big cost associated with this, their concerns about this. This is largely not covered by insurance in terms of being able to get access to this. So as you're going through this, this now starts, as you see, you know, sort of a divide. Now you start having a very wide divide in terms of access to care to be able to do this. And I won't talk a lot about it, but sociologically, that's, I think, very interesting to see what happens with that. So again, this is something that can be used quite readily. Interestingly enough, it's used more than anything else for gender selection at this point, rather than genetic conditions or diseases, but certainly something that can be done and has great clinical utility. So how can we actually change some of the dynamic, and how can we actually potentially bring a lot of value? So I'm going to use the term value in terms of really spending, at least as you can, cost contained, but delivering things that have high clinical yield. So I think you've heard me say this before, but this is now, if you think about what 23andMe offered, what they were offering were these 3 founder mutations in the Jewish population that are actually seen in 1 in 40 individuals who are of Jewish ancestry who are just walking the streets of New York. Regardless of their family history, whether they've had breast cancer, ovarian cancer, relatively common. And in fact, if you were to ask me, how much would it cost me to actually do this genotyping in the laboratory? Basically, once I got the sample and we're able to do it, we can do this for less than $100. And so if you could actually do this and, you weren't worried too much about profit in terms of doing it, given the decisions that you would make and given the fact that these are associated with things that are like 60 to 80% risk of breast cancer, 20 to 40% risk of ovarian cancer, and that with the appropriate screening you can actually prevent those cancers or at least detect them at very early stages, you can go through, and any of you that are here or listening that wanted to go through and do the cost effectiveness, this actually is an extremely cost effective test for this particular population. Hence Mary Claire King's recommendation, actually hers was a little bit more broad sweeping, but that every woman of a certain age should basically get this type of testing. I won't go as far as Mary Claire King, but I do think that every Jewish individual, every Jewish woman particularly, should think about this as an option. So this is just what you've seen before in terms of those risks. This is now just to give you a sense of the sort of different, this is like a Chinese menu for the different types of breast cancer genes that are offered. You can get everything from BRCA1 and 2, and you can get a turnaround time for this in about 2 weeks. You can get a panel of high-risk genes, also with a turnaround time of about 2 weeks to be able to make those surgical decisions. So you can go to increasingly large panels of genes, which have, in some cases, sort of ambiguous or uncertain clinical utility at this point, because we don't really know what all those genes do or exactly how high those cancer risks are, but you can get up to 25 genes, and again, with the same price that, or even much less than we used to have for BRCA1 and 2, but still I would argue in a period of time where we're still learning. We're learning very rapidly, but we're still learning. Many of the large laboratories that are doing this testing, interestingly enough, most of the research information that's coming is now coming from clinical laboratories rather than coming from large research studies. Testing companies like Myriad, Ambry, GeneDx as 3 of the ones that are doing the largest portion of this now have sample sizes that are, if you put them all together, coming up to 100,000 rather individuals, for instance, with breast cancer who have gone through this testing. And it would be lovely if we could get sort of access to that information to understand these conditions better. Probably not going to happen, but would be lovely if we could. So one of the things just to realize, and these are the pitfalls for those of you who actually do go down in the trenches to do this, is that there are certain mutations that really you're not going to detect well by things like whole exome sequencing. You'll detect better with whole genome sequencing, but they are limitations. I'm not going to go through too much detail, but some of those are, for instance, triplet repeat disorders, which really are not picked up at this point. And again, things like deletions, duplications. We have, remarkably enough, picked up Down syndrome on whole exome sequencing, but it certainly was overkill to do so, so hopefully people are not sending that for Down syndrome, although it has been done before. Again, chromosome microarray is allowing you to pick up and is a very good targeted test for specific deletions or duplications, but increasingly the technology is available to pick up that same data from sequence-based data. And so my prediction is probably 2 or 3 years from now, we're going to be doing most of this by sequencing-based data. So the big thing is in terms of thinking about when you do this. For many of us, the question is, when do I do a single gene? When do I do a gene panel? When do I just throw in the whole kitchen sink and go to exome or genome sequencing? A lot of this depends actually on the sophistication of the clinician and how good their diagnostic skills are. In a good way, I don't pretend to think that all clinicians are going to be expert diagnosticians when it comes to genetics, especially for extremely rare disorders. And so for those, I think it's great that we have basically the laboratory to help in terms of that diagnosis. There are, however, specific indications for which panels of genes are actually probably the sweet spot in terms of clinical utility at this point. So things like types of cancers, whether they be the common cancers, breast cancer, colon cancer, but even things like adrenal cancers or even in some cases pediatric cancers. That's probably the sweet spot is panel testing at this point. When people have done this across various different indications, exome sequencing probably is only giving you an answer about 5% of the time for hereditary cancers, as opposed to if you take things like intellectual disabilities, birth defects, the yield from that test ends up going up to about 35%. So just in terms of comparison for what you're getting from that. As you're doing this, as an example, for instance, this comes from one of my colleagues, Dave Bick, who's a very good pediatric geneticist. He could look at this baby and make a diagnosis of ciliary chondrodysplasia. There happened to be a specific set of genes that are associated with that, and because he can make the diagnosis by looking, for instance, at the small chest and the problems that this baby was having from a respiratory point of view, he could go in and make a very specific targeted test for this. Interestingly enough, this targeted test includes these particular genes and at a cost of basically about $5,500. I would guarantee almost hands down that for most other neonatologists that would see this child in their NICU, they would miss that clinical diagnosis. I'm not criticizing them. I'm just saying it's a relatively rare disorder you have to know about to know to do the testing. And again, if you have the option for them of something like whole exome sequencing at about the same price, what we're trying to provide for patients is basically the expertise of the diagnostic laboratories helping them out so that they don't miss diagnoses. And again, that's one of the types of things that would have great utility. On the other hand, there are some targeted tests, and so hearing loss is something that really, if you have what we would call non-syndromic hearing loss, so you just have hearing loss, oftentimes congenital sensory neural hearing loss, there are many different laboratories offering very, very good tests in terms of this, and as you can see here, just to show you some comparisons, the cost from the laboratories has a significant range. If you were to do this and go on gene tests, you'd be able to see some of these differences, but about $1,500 you can basically get an extremely good panel that'll have a diagnostic yield, oftentimes of, if it really is hereditary, something like 60 to 70%. So a good chance that you're going to come up with the diagnoses for those cases. In a similar way for cardiomyopathies, and again, if you wanted to go to, or I think I said gene test, but gene test was the old version, it's Genetic Test Registry is now the one that's currently sponsored. Again, many different companies doing different panels of genes, but panels of genes that go anywhere from about 50 to 100 genes associated with this, again, with very good clinical yield and utility as you're doing those. However, there have been a lot of labs that have tried offering things in particular for autism or intellectual disability. I will tell you that if you try doing any of those targeted panels for this, you are just absolutely wasting your time. And I think people did this with all the best of intentions. I'm not criticizing anyone, but I've talked to the folks that have done this, and the best yield they got from any of those panels was on the order of about 2%. And that's just because these conditions are so genetically heterogeneous. There's so many genes involved, so many of which we really don't know, that trying to do a targeted panel for things that are that genetically heterogeneous is really just simply a waste of time and money. And the problem we're having now from insurance companies is they've basically been through that, and they experience the fact that they paid for a lot of very expensive testing with very low yield, and they feel like they've been burned in that process. And I think that's why we're getting a lot of the pushback in terms of, explain to me why this isn't just another one of those tests that's experimental that really doesn't have proven clinical utility. So as we're doing this, that's, again, for intellectual disabilities or developmental delay that you're having those problems. And again, especially when you think you have a strong sense that there's something wrong with a child or something wrong in a family, but you can't figure out what it is. Again, this is sort of having other people be able to come and help you out with these types of diagnoses. So the big point of discussion now, and I'm sure many of you have heard this, is do we stick with whole exome sequencing, or why should we focus just on that 1.5% of the genome? Let's go for broke and let's do whole genome sequencing. There are very specific advantages. More is better to a large extent in terms of, if I had my choice, I would certainly go with whole genome sequencing over whole exome sequencing any day of the week if money were no object. By doing that, you actually get more even coverage of the genome, and I'll be glad to talk with anyone who's interested. You can actually study copy number variants more precisely. You can talk about translocations or other structural defects much better. And actually, in terms of turnaround time, you could theoretically get faster turnaround time on a whole genome than a whole exome, because you don't have to make a library or a subgenomic capture. The limitation, the real difference, though, although genome has all those advantages, is cost. And at this point, the cost differential between those two is about 5-fold. And so the best price right now, just for data generation on whole genome sequencing, is about $1,500, whereas, for instance, with whole exome sequencing, it's probably, depending on the laboratory, somewhere around $400 for data generation. That doesn't include anything else. That's just your reagent cost, but at least being able to get that amount of information. And so, at least what I would argue from the clinical point of view right now, in terms of what we're running clinically, insurance companies are not going to pay at all for the cost of whole genome sequencing. I think probably not at all, period, just because the cost to do this is going to be on the order of oftentimes $20,000 plus in terms of when you have have to do this and do this as a trio design with a mom, dad, and a child, and being able to include all the costs of interpretation. So it's a lovely concept, and I think certainly in terms of research is where we're at right now with doing that. But my prediction is from a clinical point of view, we're not going to be adopting that wholeheartedly, at least for a couple years. This is just, again, for those of you who might want to do this, realize that there are some limitations, either in terms of gene panels, exome or genome sequencing, and I won't go through all of these, but just to say it's not the perfect test, although it is the best one single genetic test that we have, and it's going to pick up, I would predict, 95% of the mutations that you're going to find. It is not 100%, and so when you don't find the answer there, it doesn't mean there isn't an answer, it just means we haven't found that answer yet. But one of the things that we're clearly finding as we do these sort of unbiased approaches to looking at a genome are increasingly these genes of uncertain significance. So these are not now just an individual variant, but the whole gene, we're not sure what it does. We're not sure if it's actually a disease-causing gene or not, but I'll tell you very quickly, laboratories are aggregating the data to see that some of these, even though they're individually rare, as we start seeing these repeatedly in individuals with the exact same phenotype, we're gaining confidence that these really are genes of now certain significance. And I can say I've pushed hard actually to make sure that we could publish these types of things. We actually have even come out with brand new journals that are specifically dedicated. We have now one from Cold Spring Harbor that are specifically dedicated to being able to get this type of information in the literature so that it can be peer reviewed, so that it can be shared very effectively, even when it's based on small numbers, being oftentimes 3 cases, but things where you have exactly the same phenotype, and you can't wait for case series where you've got hundreds of patients with these disorders because they just won't occur. So for any of you that work in this space, talk to me later, but there are places of being able to get this work published. It is strictly, I mean, it is very well peer reviewed, so it's not like anything just gets in there and gets into the literature, but at least it's in a place that can be shared. On the other hand, as you're doing this, I also want to say that I've seen way too many people, though, that have sort of been very excited in terms of thinking they've got these geese. In reality, what they're seeing are variants that individually look like they're pathogenic, but probably not that gene and that variant explaining the phenotype in that patient. And so I'm still very cautious. When you have an N of 1, you still only have 1 case, and you certainly have not proven anything, at least to my level of rigor, either for using it for clinical information or prenatal testing or anything like that. We really need to have certain rigorous standards applied, although I certainly count little furry creatures like mice, for instance. When you have a mouse that recapitulates the human phenotype perfectly, I think that really is N of 1.5 or something. You get some points for those model organisms that I think you need to calculate within that. And so one of the things to think about, though, is when you start doing that whole genome and basically independently testing 20,000 genes, your prior probability of finding something is very high. So you just need to be cautious. You will find something in every single person's genome. You need not just sort of immediately make the leap that one thing you find is necessarily going to be causative for the phenotype. We really need to be rigorous as we're trying to do that. So we're almost at the end of the hour, so I'm just going to very quickly say that we've done these types of things in terms of exome analysis, as many of you know, for about 300 patients now at Columbia. The bottom line is, as I said, about 32% of our families go home with a diagnosis from something like this. I will just very briefly say that we've also applied this in a couple sort of interesting situations, which also include deaths. So whether it be a sudden death, which is a dad that called me yesterday, or a case of sudden infant death syndrome with an unknown, you go through a complete autopsy with a medical examiner, as an example, and you come up with nothing. We now can actually do molecular autopsies, and I'll just very briefly say that this can be incredibly reassuring. This was one of the cases that we did in diagnosing. The autopsy didn't show us anything, but in fact the underlying diagnosis was a condition called Bartter syndrome. Incredibly important for the family just to get closure on this. This happens to be a renal problem associated with electrolyte wasting. This baby undoubtedly, although we can't go back and say it now, undoubtedly had electrolyte imbalances, probably leading to cardiac dysfunction, and died in bed in his crib. But important for the family to know, because this is an autosomal recessive condition, that the couple now who very, very much wants to have another baby after losing this child, this is something that has a 25% risk of recurrence. And so trying to get to the bottom of cases like this ends up being incredibly important. It's very small numbers, but we're now working with the New York medical examiners group, and actually now formally studying the babies with SIDS deaths, where we have some when we don't have an explanation, as well as other sudden deaths. And I'll just tell you, in our experience, which is very limited, but of 10 cases so far, we've diagnosed essentially either cardiac arrhythmias, epilepsies that were just undefined, and usually these are in very young children, or as I said, this case of Bartter syndrome. It's not 100% by any means, but it certainly is a reasonable yield, I think, to think about doing this. The final thing I'll say, and I know I'm way over, but at the end of the day, we've got to prove cost effectiveness of this. And I'll just say the very bottom line is that as we're doing this, if anyone's interested in a health economist, we greatly need your help, but we've started costing out what it comes to come to a diagnosis without an exome, or what it comes to cost to come to a diagnosis with an exome. What I will tell you is, even if you just include the cost directly to the healthcare system, not the personal cost to the family or the patient, to me, hands down, it's very clear that it's more cost effective, as well as time efficient, and avoids a lot of needless procedures that could have their own risks incurred with them, to do this by a very comprehensive genetic diagnosis, and doing it the earlier the better. But I will say that as a community, we need to have more rigorous sort of analyses like this to be able to demonstrate clinical utility, and ultimately to get payers to pay for this. And just finally, for those of you that are interested in the societal impact, one of the other things that's become very, very interesting is that this is now hitting the courts. So this is hitting the courts in a big way in terms of oftentimes either death or disability, shall we say. And so I don't mean to make light of this, but everything used to be blamed on the obstetricians in terms of, for instance, bad baby outcome. It was the obstetricians who did something wrong with the delivery. Now the sort of counter argument is it's bad genes. And so it's very interesting to watch the duels that are coming out in the court system. Was it the obstetrician? Was it the genes? Was it some product liability? Was it the product? Was it the genes? But just to say, it's in many cases not known still. But this is definitely becoming interesting to watch.